A while ago, I visited a large factory that manufactured coated wire. Huge reels of this stuff, many feet wide. And what I saw was robots silently moving these reels between coding machines, storage, transport, all by themselves. What surprised me was that it was an entirely paperless environment. Not a sheet of paper, not a notepad, nothing other than the lunch wrapper I saw. The factory was programmed remotely, and the one or two people were just there to oil the machines. I was told that if the old systems were reintroduced, they estimated production would fall by at least 40%. That was 25 years ago. I do understand the barriers to change. There are many reasons, both human and practical. But that's why disruptive technology is so well named. Change often has to be disruptive to be effective. The cost of the NHS of COPD is around $2 billion a year, but that figure will grow as more cases are diagnosed. COPD patients are most frequent GP users, so you blame me for having to wait to see a doctor, with the third largest group for emergency A&E and hospital admissions. So the UK likely faces a bill of maybe $4 to $6 billion a year in the near future. Disruptive digital technology, ehealth, can punch a hole in that bill. And that's why there's a movement in the health services to move away from traditional methods of delivering care. Traditional methods were often paper and creaking processes are the problem. We at Medivation are launching a digital platform that will provide Prudent Healthcare for lung disease. It starts with a simple data collection app. The patient records medications, symptoms and wellness domains while taking their medication 2 or 3 times a day as they would normally. In itself, that's a good thing. It encourages conversation and engagement with the condition. It promotes compliance and therefore increases wellness. But perhaps this will ring a bell with you. You visit your specialist and you're asked, how's it been since I last saw you? Your reply probably is, oh, not too bad. Well, ibe.mapp means that a COPD patient and clinician can have real data to form the basis of the consultation. That data is also made available to the people who need it 24/7, delivered securely to chest nurses, doctors and specialists for review or for video consultation on our platform for telemedicine. The system will flag up potential crisis points, enabling intervention before an emergency occurs, with ambulances, A&E, hospitalizations, etc. And the data will be anonymised, aggregated, and it will form the basis for the largest research study of lung disease ever undertaken. This will improve compliance with medication. It will reduce the number of nurse, GP and hospital visits. It will reduce the visits to specialists. It will save many millions for NH Wales for a start. ibe.mapp, IBE, intervention by exception. Let me give you one real-world example. In one health authority, a pulmonary specialist has a waiting list of 30 weeks, 15 if marked urgent. That specialist has little idea of what order these patients should be seen in. Does Bill need to be seen at all if he's stable? Should Harry be brought to the front because he's not? Can this case be dealt with by phone? Can this case be dealt with by video? With ibe.mapp, that specialist can apply triage. The list can be cut down by 30% and the waiting time greatly shortened. eHealth will increase the wellness of large segments of the population. It'll reduce the burdens on patients' families, the economy, clinicians, and resources, and it'll make a large dent in costs.